This is Steve Caselli. We are at the Memorial Sloan Kettering meeting in New York City, and I'm here with my colleague Dan Lenihan, and we're here with another one of our colleagues from Glasgow, Scotland, Dr. Ninian Lang. So thank you for being with us today.
Yeah, it's very nice to be here with you both in New York, which is always a great place to be in spring. I'm Ninian Lang. I'm clinical cardiologist, but I'm professor of cardiology and cardio-oncology in Glasgow. I run a fairly busy research program interested in hypertension, heart failure, mechanisms of potential drug targets for prevention, treatment of both of those things really in the future.
Yeah, Ninian, that's obviously it's a pretty important topic in general to the field of cardio-oncology. I think obviously hypertension is kind of like the most important risk factor and for the development of all the toxicities, but also it's should be the easiest parameter to follow going forward. I mean, we should be able to monitor blood pressure at home or at clinic visits, etc. So it's one of those things where you have so much information that says, yeah, we got to focus on that, but do we actually do that? And that's always a question in the mind. So what are your thoughts?
Yeah, so I think you're absolutely right. So hypertension prevalent in about 40% of patients with cancer, so many shared risk factors for cancer, for hypertension, be that obesity, inflammation, smoking, diabetes. And I think we are very variable around the world in how we monitor for this, how we treat it, and how we define it. And I think part of the issue is also that if you think about some of the definitions of what is hypertension, it's essentially the blood pressure threshold where treatment of that blood pressure unequivocally outweighs the benefit or outweighs the risk of not treating it, and that's meant to be evidence from randomized trials. And we've tried to extrapolate, I think, from the non-cancer population, and I think that's been a struggle. We do our best. We don't really know the best thresholds. The European Society has made a very good effort at trying to be pragmatic and trying to work out, in terms of competing risk from cancer, whether we've to be aggressive, not so aggressive. But we don't know. We don't know whether one drug has a greater propensity for an end organ effect versus another. So, for example, a VEGF inhibitor, angiogenesis inhibitor, maybe those endothelial effects from those drugs amplify the risk of that blood pressure number. We don't know whether it's an absolute blood pressure that's important. We don't know whether it's the change from baseline and an absolute rise, which may even still be within a normal blood pressure threshold. So there's lots and lots of unknowns, but we're still doing our best to move on and trying to follow people. And I think to come back to your initial question about how would we do this, well, certainly where I work, the oncologists have become a lot more focused on blood pressure, but we still need to move more towards empowering patients to using home blood pressure monitors. We've shown recently in a study which is also available on a preprint server at the moment, is in review, that actually clinic-assessed blood pressure is much less sensitive to picking up changes than home-based blood pressure monitoring. And whether that's because patients actually are stressed, anxious when they come to the oncology clinic, that actually those fluctuations aren't quite as ready to see. So what we tend to do is we try to get our patients to monitor their blood pressure at home twice a day for the first cycle of their treatment, and then to become a little bit tailored down from that. But of course you've got to balance this, the context. Cardio-oncology is all about that balance, which is what makes it rewarding, but also what makes it challenging.
Yeah, I think, especially coming from the heart failure space, if we can get somebody to weigh themselves and measure their blood pressure every morning, at least once a day, or do it once a day as a routine, then, that's a huge victory. And so whether we try to just measure blood pressure at a clinic visit, which only happens every so often, then we're not detecting reality by those periodic blood pressure measurements in a clinic. So doing a home-based monitoring strategy, which however that gets done, is crucial to actually treating it. And the other thing is, it's one thing, when we talk about whatever monitoring strategy we're talking about in cardio-oncology, it's one thing to do the test or to monitor for the problem, but it's what you do with the finding that matters. So it's not just to detect an abnormality, it's like, okay, I detected it, now what do I do with it?
Yeah, exactly. And I think that's been one of the biggest barriers. And I think taking away that fear from oncologists, patients, nurse practitioners, I've already spelt out to you how I find it a challenge, and I'm a cardiologist and I'm supposed to know what I'm doing in this area. But I think if you link the blood pressure monitoring with a guideline, and probably more importantly, a telephone number, an email address of a cardiologist to help with those decisions, I think that will actually encourage the test to be done. People don't like doing tests, but they don't know what the answer is. And the other point is that actually, to change the mindset a little bit, I think, certainly in my own practice as the oncologist, is that cardio-oncology and measurement of hypertension is not here as a barrier. It's not seen to be something to be used as a decision to interrupt treatment. That's very, very rare. But what we really want to do is to allow blood pressure to be well controlled so that actually the optimum treatment can be continued. What you don't want is the onset of heart failure, for example, because of poorly controlled hypertension, and a patient who can't receive treatment, for example, for their kidney cancer. That's the worst of all worlds. And I think that message is becoming clearer and clearer. We're not seen as such a threat, perhaps, to the oncology treatments that we might have once been.
And I think also, really from a cardio-oncology perspective, I think the oncologists already have so many things on their mind about, whether to, review the imaging that was done or the pathology or, some sort of genetic test or whatever they did, and they have to go over those details with the patient. They're not going to spend time dealing with high blood pressure, even if it exists. And so I think our role as cardio-oncologists would be more about how to manage that problem kind of in the background so it stays in the background, and but do it in a more effective way. So having the patient engaged is the simple and most effective strategy, however you plan on doing that, however you can get them to be engaged is the most important piece.
Yeah, I completely agree. I think the biggest single marker of engagement is actually encouraging and realizing that patients will measure their own blood pressure. That's in my eyes, that can only be a good prognostic sign if a patient is engaged to do that. And then you say the oncologists are extremely busy thinking about cancer at centre, but a whole range of potential toxic effects, not just cardiovascular. And so if there's a way of linking electronically and home blood pressure readings or even clinic blood pressure readings that come to a central server or node for distribution to an interested cardiologist, cardio-oncologist, the nursing team, I think that taking it away from the oncologists to an extent is probably what's going to push things on further than that.
Yeah, and of course there is truly a balance between information and too much information.
Yeah.
And so we have talked in this meeting and at other meetings as well that, depending on the condition, you may opt to do some sort of monitoring strategy. So in the case of blood pressure, doing home blood pressure monitoring tool, whatever you use, basic blood pressure cuff, if that's the tool you want to use, or you do ambulatory blood pressure monitoring, or in the case of heart failure, you can even do an implant. You can implant a PA pressure monitor, and I actually was part of clinical trial doing a left atrial pressure monitor, and I mean, talk about way too much information. You have somebody's left atrial pressure changes, in mid-sentence. They get a little angry and all of a sudden their left atrial pressure goes up, and that sends an alert to a monitoring cardiologist. I mean, that is way too much information. So how do we balance those things?
Yeah, I mean, I agree. Information overload is anxiety producing for everyone, including the patient, which probably puts their blood pressure up even further. So I don't know. I think, the easy answer to everything at the moment is, AI will sort this out.
They'll sort it out, but whether they'll sort it out accurately is another question.
It needs a filter. I think we need, what are the big picture pieces of data that we need? It's, what is the blood pressure? Or even, has it gone above a certain threshold? Yes, no, a binary outcome. Has it risen by more than 20 millimeters of mercury? Yes, no, binary outcome. It can be as blunt as that, and it could be tailored to your patient. But you're right, I mean, it creates a huge amount of information, and CardioMEMS has not taken off particularly as much as it might otherwise have done, not just because of cost and difficulty, but because of this information overload and how do you link that to an outcome? The information is only as good as the therapy that you have that's tailored to that in the end. It's all well and good collecting stamps and looking at pulmonary artery pressure, but you've got to do something about it in a meaningful way.
Yeah, and I think that's for a device, monitoring, all of the, contemporary devices, ICDs and pacemakers and all that, they have a huge set of parameters. I mean, back in the day when I was running a pacemaker clinic, it had like 2 settings and one basic heart rate monitor. That was it. And so it was very easy to look at a device and see 2 or 3 points of information and you make some decision accordingly. Now, if you interrogate a pacemaker, for example, there'll be 25 pages of output with 6 or 7 graphs on each page. And so, you're looking at 100 different data points that you could follow and make some decision. So what is the essential piece as it relates to high blood pressure, since let's just try to stay focused on that question? What is the essential piece that we have to act on?
Yeah, so I would say we still do not know. We like to think that this magic 160 over 100 millimeters of mercury is the sign where we need to really stop and think and be more aggressive in our treatment. But I still would argue that we do not know that that is absolutely correct. And even if it's relevant to one patient, is it relevant in the context of a metastatic cancer with incurable disease versus someone with an early breast cancer? So these are unknowns. I'd love to have the answer, but I just don't think we have those yet.
No, I'm sure we don't, but I think it's always, I feel like it's always important to remember, for us collectively, that more information is good to a point. And we want to do things that are practically useful or ultimately improve the outcome. So we don't want to do things just to get more information. Yeah,
so I think we have to get better evidence, and we have to look at the big picture. If you're talking about blood pressure, you talk about the headline figures, which I've mentioned, but you've then got to look in your trial and see whether or not there is utilization. Does anyone look at these data? What do they do with the data? Does that affect outcomes? Does that affect cardiovascular outcomes? Does that affect cancer outcomes? So, one piece of data opens a whole can of worms.
So you had mentioned some of your research that you're developing right now. Could you maybe tell us a little bit about what you're up to?
Yes, I'm very interested in thinking about mechanistically linked prevention or treatment therapies for patients with a degree, with most different types of cardiotoxicities, whether that be hypertension or left ventricular dysfunction. I think we've been challenged, shall we say, with primary prevention trials in that we've tended to look at beta blockers, angiotensin receptor blockers, ACE inhibitors, and I'm not certain that we're using the right drugs. We're using heart failure drugs essentially to often try and mitigate potentially direct cardiotoxicity. So I've been looking, actually in some ways, and similar to a trial or a study that you did years ago, at patients on angiogenesis inhibitors. This was work done, supported by the British Heart Foundation and a very talented research fellow called Stephen Dobbin, and following up around about 80 patients, very comprehensive blood pressure, echo, biomarkers, stress perfusion, cardiac MRI, and looking really to see what happens to the blood pressure, what happens to the cardiac function. But the real striking thing is that actually we've seen a substantial instance of left ventricular dysfunction, substantial instance of high blood pressure, but also a striking elevation in endothelin levels. So that then raises the question, given that some of the preclinical data suggest that renin-angiotensin system aren't necessarily involved in these processes, is there a role for bringing old drugs back into the realm? So, for example, endothelin receptor antagonists. Zibotentan was developed as an anti-kidney cancer drug, and was used for a period before angiogenesis inhibitors came along. So it begs the question, can we use drugs like that to prevent endothelin activation, microvascular dysfunction at the level of the coronary, of the myocardium, potentially in the peripheral vasculature? And can we use those drugs to prevent or treat those problems? Now, it's fairly intriguing. There's development of combination therapies. Zibotentan endothelin receptor antagonism, as you know better than most, was associated with fluid retention, potential heart failure issues. Now, that may be different in a population where they have endothelin activation as your primary target. But these drugs are now being combined with SGLT2 inhibitors with the aim really of mitigating this fluid retention effect by combining with an SGLT2 inhibitor. And we're told that SGLT2 inhibitors on their own are a cure for everything. So in this particularly target, they might not be, they might be. In this particular group, this seems to be a fairly thought out rationale for endothelin receptor antagonists in this very specific group. Whether it's got a wider application in cardio-oncology remains to be seen.
That's interesting. And there were the endothelin receptor antagonists were studied pretty extensively in heart failure. You know that. And they never quite got over the bar, Mm-hmm. They kind of showed some positive results here and there, but nothing really ultimately convincing. And maybe it's because it wasn't apropos for the whole spectrum of heart failure. Like you say, is there a specific population that would very much benefit from that? And that's an interesting question. I certainly don't know the answer to that, but.
Yeah, so I think my memory serves me right. I think that the higher risk patients were noted to have a higher NT-proBNP at baseline. So if this is in prevention group, it's a different population anyway. The Zenith CKD trial recently using this drug has been encouraging, has found a suitable dose for the drug. So, hopefully we can watch this space. But
nice. Oh, that's great. Well, yeah, we always, I think, there's the practical side of things, and where we just gotta really struggle with how do we do things in the real world situation. But then many of our decisions have been guided by basic science, studies that pointed us in a certain direction. So it's really key to have both of those things going on. Sure. So I applaud your efforts to really dig into the details there.
Yeah, thanks. I think I see it actually. I see cardio-oncology and heart failure with preserved ejection fraction having some similarities. We struggled for years and years and years to find potentially effective treatments for patients with HFpEF, but we treated them as a homogeneous group. But it's only now that we're drilling down slightly more phenotypically, mechanistically, that actually we're beginning to find there are potential treatment options. So then when you come across to cardio-oncology, do you want of course we want a big one-size-fits-all, we want a wonder magic bullet drug that's going to protect everyone from everything. But we're not really there. I think we need to be a little bit more focused in phenotyping and understanding those populations that really serve to benefit the most.
Yeah, no, that's totally true. I think if you go back and you look at the HFpEF, quote, HFpEF population, whoever that was, and it depended greatly on how the study was organized and the demographics of the place wherever the study was being done, and et cetera, et cetera. So in one population it might be sort of resistant hypertension as a cause of HFpEF, Whereas in another population, maybe there was a 10 or 15% incidence of amyloidosis as an underlying condition in that population, and those two demographic groups are not going to respond the same to therapies. So yeah, I mean, HFpEF has been a challenge, mainly, like you say, for characterizations.
Yeah, couldn't agree more. And I think the other final thing to say, I think the other challenge in cardio-oncology is finding a drug that prevents or treats the cardiovascular issue without interfering with the anti-cancer effects. And certainly zibotentan, the endothelin receptor antagonism, that we feel relatively relaxed about that because of its history. SGLT2 inhibitors, there's pretty good data coming through now to suggest that they don't have any adverse effects, and then some preclinical suggestions that they may even be helpful.
Oh, well, definitely in the heart failure world, I mean, SGLT2 inhibitor is good for what ails you, whatever it is.
Yeah, well, even if it's cancer.
That's right, so, and if they didn't cost so much, I mean, they should be in the water.
Yeah.
But, I think those are really profoundly good drugs. So, well, no, this has been very interesting, and thank you so much for talking with us today, and we'll look forward to whatever you're going to come up with soon. So.
It's been great to chat. Thanks very much.